you might have to give further sections in the sample, and that may need some extra time. So you may exceed your turnaround time, but in those cases, the thing that you have to do, that the most important thing is that you have to call up the clinician and tell him or her that this is the problem with the specimen and this is the reason I am exceeding the turnaround time. So that will help solve the problem, and that will help actually not create the problem in future, because unless you communicate with your clinician, that is the reason which actually creates the problem in the future. Next is history and background of the patient. Now, most of the cases you have seen, the pathologists have seen, or the laboratorians have seen that there is no history background of the patient or incomplete history and background of the patient in the requisition forms. Now, why so? Because there seems to be a perception amongst many clinicians that the history of the patient, if provided, may cause bias in reporting. Now, that is actually wrong, and most of you know that diagnosis is often more accurate and sometimes can only be made in the light of other clinical information. Now, withholding information from a pathologist, or for that matter, microbiologist, biochemist, not only demeans and ignores his expertise, but also increases the likelihood of the error. Now, you see, this is an example of a requisition form from one of the institutes, and you see there is no history at all in this requisition form. So, and whoever has sent the requisition form expects the, this was sent for a dengue serology, and there is no, whoever is the requisitioner does not even care to write that the patient had fever. The next requisition form says stool in blood. I have never heard of presence of stool in blood, but then yes, whoever has written this has sent it for culture and sensitivity of urine, and that person had a clinical diagnosis of stool in blood. Then this requisition had said gay, no problem. So fine. The requisitioner had no problem with no problem with any sexual orientation of the patient per se, but then that does not serve the purpose of the investigation which was ordered. Now you can see from this clause of NABL, ISO 15189, which clearly says that 5.4.3 request form information, which clearly says that clinically relevant information about the patient and request for examination, performance, and result interpretation purposes is one of the mandatory things that is required. It is not so that out of the blue, a pathologist or a microbiologist or a biochemist is asking the clinician for a definite clinical history. It is one of the requirements of ISO 15189. And why only quote a definite guideline? It is everybody with the sane mind would think that a history would definitely help you to give an appropriate and a correct diagnosis. Coming to comprehensibility of reports. Now, when we were talking about ideal clinician in the eyes of a pathologist, we talked that a pathologist wants that the clinician understands each and every jargon of his report. Now, you should understand that just as medical language may be hard for lay people to understand, pathologists may also use language that is sometimes obscure to practitioners outside the specialty. So, that is why we should adopt some means and policies. We should not end up giving this kind of reports, which is absolutely of no use to the clinicians. So to do away with such problems, standardized reporting formats like the Bethesda system, the College of American Pathologists protocols, which we call the CAP protocols, etc., need to be adopted. And this is what we call the synoptic reporting. Now, what is this synoptic reporting and what is its importance? Now, synoptic reporting is a process for reporting specific data elements in a specific format for surgical pathology reports. Now, previously, surgical pathology reports were highly narrative. You have seen, or if any clinicians attending this meeting must have seen that even during our postgraduate days, we have seen that we used to write a page or 2 pages of surgical pathology reports when we were giving out reports from our department. Section shows this, and then finally at the end of the page, the interpretation, if at all possible. Now, what happens there is that narrative is not useful to the clinician. He does not know, or he is not bothered actually how your nucleus looks like, how your cytoplasm is, or how whether the nucleus at all has a nucleoli or not. So in practice, the College of American Pathologists has been promoting synoptic reporting for the last more than 20 years and has published protocols with both required and optional data elements for at least a decade. And for practicing pathologists, a synoptic reporting refers to specific elements in the cancer protocols and a specific format required by the checklist. And for clinicians, how is it useful? It provides a checklist that ensures completeness of reported data elements. Now, they know that I need this data in the report, and they will just tick the checkbox in the checklist. So they will know that I need this specific kind of report this specific data elements in the report, and those data elements have been reported by the pathologist. I'll give you an example. Now see, this is an example of a TURP specimen which has been reported by a non-synoptic reporting. So section shows abnormal glandular architecture with single small infiltrating glands, wide stromal separation and occasional crib forming and fusion of glands, blah, 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 blah. Prominent macronucleoli. Above features are consistent with the diagnosis of prostatic adenocarcinoma. Only thing the clinician is interested is with prostatic adenocarcinoma. Hey, what does he know about crib reforming? What does he know about stromal separation? Now, during MBBS, if you remember, we used to read about those pink boxes in Harshmohan, which when we have specialized, who have not specialized in pathology, have forgotten in 100% of the cases, they have forgotten about those pink boxes, what was written in those pink boxes. Now, in pathology, we again, our life is all pink and blue, and we want, to see the life of clinicians also as pink and blue, but it is, it is not possible. So we have to actually give reports which are understandable, comprehensible by the clinicians, and which are actually of use. Now, when I say of use, it has to be of therapeutic use by the clinician. They have to understand the report and act on it. They have to be, we have to incorporate elements in the report which would be of help in treating the patients. Now, only giving a report of prostatic adenocarcinoma would not help the clinician decide the treatment of the patient. Now, what is a synoptic reporting? Now, if this is the report, you see, this is a very concise, precise report, and it helps the clinician to decide the treatment. You say the specimen is TURP, diagnosis is prostatic adenocarcinoma. You say the Gleason score is 5+4, 9, whether there is perineural invasion, whether there is lymphobascular invasion, and what amount of tumor you have examined. Now, based on this, you have given the prognostic factors of the carcinoma. You have said what type of carcinoma the patient is suffering from. And based on this, now the clinician can decide what type of treatment the patient would be subjected to. So this is what a synoptic reporting is. Now, the key problem to everything is communication, whether it is verbal, whether it is written, but the problem is communication. So consultation and collaboration are the key to planning procedures and sometimes even therapy. As I told, here is the problem. If you do not communicate properly in your report, the therapy will go haywire. So only by communicating and balancing your needs, your priorities, clinicians and pathologists can accomplish their missions. So it should not, your communication should not rely solely on chance encounters in the hallways. It should actually be planned. So it should create ideal balances of quality and convenience. And what are the barriers to communication? So the potential barriers to effective communication are mostly the lack of, technology, logistical issues, but all these things can be taken care of. Now, this is a book which talks about error reduction and prevention in surgical pathology. It's a very good book. If you happen to come across, so please go through it, which says, there's a very beautiful line here in this book, which says that a mystic perversion of this assumption prevails among those clinicians who believe that the pathologist, given only a piece of a patient's tissue, has all the ingredients necessary to produce a statement of absolute truth at the end of his report. That means that the clinicians feel that only giving a chunk of tissue to a pathologist maybe in a bottle of formalin, sometimes not even formalin, sometimes even saline, worse, even in water, and he feels that a report will be generated out of it. No history, nothing. Now the next line is, all the more dangerous to mankind is a pathologist with the same concept. I have come across pathologists who feel that any report can be generated from a chunk of tissue. No history is required. Nothing is required. A chunk of tissue is sufficient to generate a report. So that kind of pathologists are more dangerous to the mankind. Now, what are the solutions to a better relationship? You should create hospital laboratory review boards where you have opportunities where clinicians and pathologists can discuss the problems. You have clinico-pathological meetings regularly, integrated teaching sessions. Now, these teaching sessions have been incorporated by NMC now. We are having integrated teaching sessions with the undergraduates. It's a very good opportunity to talk about these problems. Participation of pathologists during clinical rounds, if possible. So you have pathologists going in the rounds with the clinicians. When we were working in Tata Medical Center, you will, people who have worked there should know that the microbiologists used to participate in the clinical rounds, because without the consent of microbiologists, no clinicians would even think of changing antibiotic course. So that is how it functions there. Establish training goals for clinical residents in pathology, and you have computer technologies like LIS, RIS, HIS. So those things will help creating a better relationship like this. And how do you ensure quality of reports? Now, if you want to gain confidence of your clinician friends, you have to ensure that the report that you release has to be of a particular standard, has to be of a particular quality. So for that, you should establish an internal quality assurance in the laboratory. You should have external quality assurance scheme, and you have to monitor the machine generated reports by the faculty members. So always machines do not give proper reports. Sometimes the machine gives you erroneous reports, so that has to be monitored. And if there are errors, you have to find out the root cause of those errors. So these are the agencies or the boards which actually control your quality, like the NABL, you all know, the CAP, and also the JCI. So these are the most commonly heard of accreditation bodies, NABL, CAP, and JCI. So if you have these accreditations, people would know that your reports, your lab is of a certain quality. Coming to the last part of the session is, do pathologists need to communicate with patients? Now, just the other day, maybe only yesterday, I was talking to my PG students and I was telling them that this is an era where the pathologist should come forward and talk to patients. And why? Because it is not the same era where the pathologists used to sit behind the closed doors with their eyes glued to the microscopes, and sometimes even to reference books with little or no interaction with patients. Nowadays, the pathologist is expected to have effective communication, not only with the clinicians, but also with the patients. Now, this may be an eyebrow raiser for many who think that it is only the clinician's prerogative to interact with the patients, but then the fact is fact. Now, why do pathologists need to communicate with patients? Most of the time, you have seen that the test requisitions are not accompanied with a proper clinical and therapeutic history, like I have said. So, the easiest way to find out the history is talk to the patient. FNACs come to you, you don't have the history written on the requisition, talk to the patient, you will get the history. So that is how you find out the history. So one of the very important messages which was given by Terry Canal in his vice presidential address, he said, the patient will never care how much you know until they know how much you care. So if you do not show that care to your patients, they will never come back to you. So you should come forward and show that care. And you should communicate, because when you communicate, you have to have that art of listening. You have to listen to your patients, because this is one of my favorite quotes by His Holiness Dalai Lama. He says that when you talk, you are only repeating what you know, but if you listen, you may learn something new. You have seen that patients keep wondering and worrying about the report interpretation. When you release a histopathology report, they do not understand what is written in it. So until they get the appointment of the next treating clinician, so they do not know what to do with that report. So why don't you come forward? Why don't you come forward to talk to the patients when you dispatch such reports and try and explain the findings to them? So that would alleviate their pain, alleviate their anxiety. So, and they will be spared of unnecessary worry. So if you communicate properly, so that will generate a feeling of confidence and well-being in the patient. So that is how you can communicate with the patients when you are dispatching a report of histopathology, a malignancy report. That is why I always say that breaking bad news is an art which pathologists should try and acquire. Breaking bad news is not an art which only the clinicians should acquire, because most of the time these malignancy reports are released from pathology department, and a pathologist should know how to break bad news. Because if you are one of those pathologists who would want to communicate with patients, communicate with the patient party, you should acquire that art of breaking bad news. Now you see, there is a concept of pathology explanation clinics. Although we in India, we are trying now, I'm talking to you regarding pathology. Pathologists should communicate with patients, should communicate with patient party. The Western world is always in some domains, they are always ahead of us. And they have already established this concept of pathology explanation clinics. And what do they do there? These clinics are basically envisioned to discuss test results with the patients. And the goal of these clinics would be to help fill the gaps in communication of information, content in the laboratory reports to patients, and further explain its relevance and improve the patient understanding of the meaning of such information and the impact on their health and healthcare choices. Just the same thing which I was telling you. Like you want to, if the patient does not understand a certain thing in the report, so you come forward and explain the same thing to the patient party. So that is what this pathology explanation clinic is doing in the Western world. They have given a fancy name to it. And this was, the concept of this was published in 2018 in this journal. You can just go back and have a look at this article in this journal by Gibson et al. And on this pathology explanation clinic. And coming to the end of my talk, the last two slides, I always say that remember that when you are working as a pathologist, not only pathologist, as a clinician, that besides our clinical skills, besides our skills in the lab, there are 5 things that will protect you from any medical legal problem. When we are talking about a communication between the clinician and the pathologist, that these are communication, then documentation, communication of documentation, documentation of communication, and finally preservation of documentation. So these 5 things are the primary things which will help you to save yourself from medical legal problems. To summarize, this collegial and cooperative relationship between the clinicians and pathologists is indisputable, and its potential for positive impact on medical care is too great to ignore. So we cannot ignore this, and effective communication, trust, and reliance on each other's expertise are needed. Why? To rebuild and strengthen the relationship between the clinics and the laboratory. So we know that we can achieve more when we are together than we are apart. So this is an era of patient-centered care. So therefore, we as pathologists, we should try our best to expand our roles. So that is what I was saying. We should not just sit in our rooms and just keep looking at our microscopes. We should expand our roles, broaden our outlook so as to provide a holistic and better care to our beneficiaries. And who are our primary beneficiaries? The patients. And this we can only do if we can come out of our own comfort zones and try to comfort the patients in their agony. So we bear the responsibility of our patients, and failure to do so may have diagnostic, therapeutic, and legal consequences. So that we have to remember. Now, finally, coming to this concept of Venus and Mars, there was a lot of argument on this. Clinicians did not want to, identify themselves as a Roman god of war, and why they said that why should pathology be, tagged as a goddess of love, and we are not always at war. So then finally in 2008, this article came out where it said that pathologists are from Mercury and clinicians are from Uranus, just to identify that these two group of people are just from different planets. They don't identify themselves to any particular god or goddesses. So thank you all for lending your ears. That is all for today. Thank you.